All right, 15.3, the substance abuse section. Generally, there's a lot more fun one to have class discussions with, but we're going to get through what we can just to deal with this semester. All right, so a couple of terms that you need to know: addiction and kind of versus dependence. So when we're dealing with substance abuse issues and kind of our defining characteristics, abuse is where people use it, and it may have some debilitating effect on their life and not necessarily be in the realm of addiction. So if we have someone that's like a weekend warrior drinker, they only drink on Fridays and Saturdays, but end up with multiple DUIs, we may be talking about more of an abuse spectrum. Addiction is where we start to see it become debilitating in multiple components of their life. You can have addiction and abuse overlap. I'm also just trying to give you the definitions for test purposes. So abuse is kind of an overconsumption of that may have some consequences. Addiction is where we start to see debilitating effects occurring in people's lives, and not that debilitating effects can't occur with abuse. Dependence, typically when we're talking dependence, we're seeing some type of physical withdrawal. This is like the DTs that come with alcohol or benzodiazepines, the withdrawal effects from heroin and such. There is some discussion, debate as far as dependence with some behavior-based addictions like gambling. That there's not necessarily that you see the withdrawal effects or kind of the shaking that you would see with physical withdrawals. However, there can be a dependence if that particular behavior or substance is used for, it's needed for escape avoidance type behaviors. So where most of our drugs of abuse come into play is that it causes an abundance of dopamine production in the nucleus accumbens. And this is where we do see some of the behavioral addiction stuff come in. Some MRI studies have shown that when we look at the nucleus accumbens firing, when people are like pulling the arms on slot machines or getting ready to scratch lottery tickets, the nucleus accumbens fires as well as when people are using drugs. So we start to see this euphoria that comes with certain drugs and uses, and we're going to talk about some of those as we move through this section. So definition-y stuff. Tolerance is where you need a higher dose to feel more of the effects. Just for sake of example, if it took you a 6-pack to get buzzed your freshman year, and now your sophomore year a 12-pack, and then your junior year an 18-pack, and then your senior year a case of beer, now we're talking tolerance. Withdrawal is the withdrawal effects or the unpleasant physiological sensations that come with this. Withdrawal can occur it's a pretty wide spectrum. So we have some severe withdrawal effects that you may see with like alcohol or benzodiazepine, which could be deadly. The delirium tremens in severe alcoholics can kill people, which is why they still have these 30-day detox centers. And some people have to go in the hospital. Heroin and cocaine withdrawal, it sucks and it won't kill you. Now, people may report they feel like dying or they feel like they are dying. And there's even like lower level withdrawal effects. A hangover the next day is a withdrawal effect. Any of your friends that recommend, hey, just drink a beer the next morning or hair of the dog to help the hangover go away, really bad idea, because now you start moving yourself into some of the addiction and tolerance potentials. So just kind of our graphic here of where the nucleus accumbens fires. There's a whole bunch of other stuff going on as well. We see the euphoric feelings of the different substances that come in the frontal lobe, and this is why people choose different drugs, because there are different personal preferences of what euphorias they like. So the disease model, this is one that's kind of debated. Some people ascribe to the disease model in the sense of if it's a disease, it can be treated. Other people are not too hip to the idea of a disease model because they argue if it's a disease model, then it can be used or justified more of a reason why people don't stop doing. There are professionals on both sides of the camp. I'll leave that for you to kind of think about as the way that it's framed. So nicotine is one of our stimulant-based drugs, and it's transported a number of different ways. Smoking and smokeless tobacco, like chew, are the typical transports. There are nicotine patches, so there's this dermal layer. There are actually nicotine hand salves that have come out. They never really caught steam. There's the aerosol transports, which is in all the vaping devices today. Um, some of the research on nicotine is it is one of the most difficult substances to quit. And it's not that nicotine itself is quote unquote so addictive. It's with nicotine in the state dependent learning processes, we pair nicotine use with many events in our life. So that makes it a heck of a lot harder to quit. Because if you smoke when you wake up in the morning, and you smoke with your cup of coffee, and you smoke on your way to work, and you have a smoke break at work, all of these things are now pairing your life with smoking. It's one of the few substances that you can still take a break for. So if you're at work, you can tell your boss, I'm going to go take a smoke break, and you're usually not too stigmatized or judged there. But like if you tell your boss, hey, I'm going to go take a cocaine break, you may lose your job. So dealing with alcoholism, it's a habitual overuse of alcohol. There's a couple of different schools of thought on this. There's type 1 of the old school schools of thought, and it still has some traction, is type 1 versus type 2 alcoholics. Type 1s are your kind of everyday drinkers, and they may be people that have a martini at lunch, and then they have, a drink on their way home from work, and then they have, a couple of drinks with dinner, and then they have a drink or two to wind down before going to bed. And they may kind of maintain a steady baseline of their blood alcohol content or their BAC and not really get, quote unquote, drunk every day. The type 2 alcoholics are the people that tend to binge more. So you'll see type 2 alcoholics may not drink all week and then cut loose on Friday or Saturday. Or they may only drink on like holidays. Someone that gets hammered on, New Year's and then 4th of July and St. Patty's Day and these types of things. But when type 2s drink, they tend to overconsume to a point of intoxication. Chronic alcoholism is very difficult to treat. This goes back to the last slide we talked about with smoking, is that alcohol is paired with many things in daily life. So there's that state dependent process that comes in, and alcohol is readily available to many people. You can go to any grocery store or ABC store and get booze, to where if you're having to buy drugs, there's site specific places you need to go to do this. The outcomes are better for treatment if we can catch people early, as well as identifying risk factors in populations. So like I already mentioned, the type 1 and type 2 in the last slide. Type 1, sometimes you'll hear as referred to as quote unquote functional alcoholics, because they're able to make it through their day, and not everybody is quite aware of this. And then the type 2 people are more bingy folks. There is some theories that type 2 alcoholism may develop more prominently in college age individuals, because that's kind of the college lifestyle, versus people that are 18, 19 years old coming straight out of high school into the workforce. The data is a little mixed. So our risk factors, there is some genetic predispositions here. And this is what we tend to see with type 2 alcoholism too, is that people that have alcoholism around their family, we see more type 2s. And it is possible with no family history for any addiction to develop. You continue using something, you'll develop an addiction for it. However, family history is a correlate that plays a role in this. Other factors, parental conflict, divorce, inadequate supervision. If people aren't monitoring their kids, and their kids are able to get drunk and not be held accountable for this. Victims of abuse or survivors of abuse can increase the potential for these. Culture also plays a role, and when we talk culture, this goes beyond just like people in the U.S. versus people in Europe versus people in South America. There are subcultures that exist within as well, where we see prevalent rates between different national groups as well as different ethnic groups. It is difficult to treat alcoholism. There's about a 10 to 20% success rate. Relapses are very common. There's a number of different treatments that are out there. There's, therapeutic treatment modalities, talk therapies that are available. There are some pharmacological treatments. They're not used as often anymore. We'll talk about one of them here in the next couple of slides. Antabuse is one of the old school ones. There are some newer medications that are being used off-label. There's some antidepressants and mood stabilizers that are finding some promising effects, not necessarily for treating alcoholism per se, but what it ends up doing is reduces the urge to use. And so people are able to kind of stop using more efficiently. This is often done in conjunction with some type of talk therapy or behavioral therapy. There are other like not-for-profit groups like AA. The data on AA is very, very mixed, which, I mean, it makes sense. If you're trying to survey an anonymous group, you can't collect information from anonymous people, and that makes follow-up studies really difficult. That makes good evidence-based science difficult. And whether not to get too hung up on data, it's free, it has helped people, and it's out there. And lots of times people in AA are they're doing some type of mixed anyway. They're in therapy or some type of medication management as well. Antabuse, like I mentioned in a previous slide, is one of the old school treatments for alcoholism. It's an aversion therapy, and the idea behind Antabuse is, well, the way Antabuse works is if you take it every day, and if you consume any form of alcohol, it makes you violently ill. And so the idea behind this was that people would pair this kind of analogous to like food poisoning. They would pair this getting really sick with alcohol and stop drinking. The treatments for this have shown very mixed outcomes. Once people stop taking Antabuse, they can start drinking alcohol again. If you consume anything with alcohol in it, so like if someone made you a cake and used vanilla extract that had a really low amount of alcohol in it, you're going to get sick. So this is where there's some turnoffs to this, as well as like, trying to court mandate it for people is really difficult to follow up on. And so the data is not so great on Antabuse. Some people still will voluntarily get it from their prescribers. It's just not something that's frequently used today. Controlled drinking or moderation management comes in a harm reduction model. It surfaced in the 80s. It lost traction, and then it's picked traction back up. And it does come in with this idea of teaching people that you can drink wisely or smartly or use. Moderation management came in primarily with alcohol and has been translated to other substances. And the idea behind it is teaching people, if you're going to use, how to do it as safely as possible. So some things that come out of moderation management is that it's record keeping of the drinks that you have. It's bringing cash with you. And once that cash is spent, you leave the bar. It's bringing little cards with you. They have these cards that you can bring, and you have to tally each drink. And then once you've reached your tally of drinks, it's either go home or you just switch to water. The data is tricky. It's not a model that works for everyone. What's probably going to happen is the moderation management, harm reduction will work best if we catch people early. Someone that's a 15, 20-year veteran drinker, a moderation management program is probably not going to work too well for them. Versus if we find like an 18 or 19-year-old kid passed out drunk, in the dorm bathroom, this might be where moderation management could be a potential option versus an abstinence-only model. Opiate dependence. This is one that's gotten a lot of traction in the news lately because there's a number of opiate addictions that have developed as a result of overprescription of painkillers. So the treatments for opiate addiction, they vary from different pharmacological methods to talk therapies to partial hospitals, inpatient stays, and things like this. Methadone is one of these that people are prescribed, and methadone helps kind of stave off the withdrawal effects. Has a considerably less euphoria depending on who you're talking to. Some addicts do report a mild feel good that comes with methadone. Suboxone is another one that is recently being prescribed, and the way Suboxone works is it blocks the opiate receptor site, so if someone uses, they can't get high. Um, so just kind of like with Antabuse, once people stop taking Suboxone, they can go back to their drug of choice, as well as with methadone. Um, and where these get tricky too is people that are taking drug tests for works, they will pop positive for an opiate if they're using, methadone or Suboxone. So dealing with substance abuse in society, it's a controversial topic because some people look at it as a moral issue, some people look at it as a legal issue, some people look at it as a pharmacological issue, some people look at it as like a neurological chemical issue, some people look at it from a behavioral perspective. Um, there are a number of treatment modalities out there. There is wide stigmatization that comes with drug use. Um, there is a bit of a push for a harm reduction model and a decriminalization and more of an education on wise use versus just an abstinence only model. Until we have better data, it's really hard to say which is the best one. And with people, so many people varying in genetics and environmental cues, there's probably not a one size fits all model.